Good morning. Can you hear me, Jamal?
Yes, I can. I said,
Oh, okay.
good morning again, but I was on mute, of course.
I always think it's me, right? Not working.
Yeah. You're not Brittany this morning.
I'm, I should have had her set that up for me as me, not her.
Yeah. Well, in due time, we always get these technical glitches eventually worked out.
Yes. I just delegated the setup to her. And she's like, I think she's more mortified than me that she used her name and that I have to
Oh
do
yeah.
her.
Did you catch the thunder
Oh my goodness.
and
I was
lightning last night? Yeah.
yesterday here at the office. When was it? Like 4:30? There
Yeah.
was a thunder right over the building that it sounded like something hit the roof and it shook the whole, I could feel it in my feet. I was on a meeting
Wow.
and they could hear it. It was crazy.
Yeah, yeah. I think yeah. No, I was here in the office myself and I was talking to Josie and Trisha and same thing. Like just kind of halted all conversation and
That
yeah,
it sounded like, the 4th of July, the boom, and
yeah,
it
exactly.
rattled.
All right, I see folks joining on. We've got Carlos and Melissa. Good morning.
Good morning.
Morning, Jamal, and everyone.
Good
Hi,
morning.
Melissa.
Oh, my camera's not.
Give it some time here for folks to join. Hey, good morning, Angie. Welcome.
No, don't worry, it's not recording you.
Hey, Bruce. Morning.
Good morning, Jamal. How you feeling? Better?
A little bit better. My nasal passageway is still a little bit clogged up, but if you couldn't tell in my voice, but I'm here, I'm kicking.
Oh, man, it's going around. Trust me, noro and flu, and it's just
Oof.
bad.
Yeah. Noro's the worst. I'm glad I didn't have that. See that Jill's joined. Welcome, Jill and Caroline and Russ and Phil and Chris. Good morning to y'all.
Morning.
Jill and Lisa,
Morning.
I think we should maybe give it a couple more minutes for folks to join in. See Dr. Hatler's joined. Hey, Matt. And Manu. Good morning, Manu.
Hey, good morning. I'll be
Well,
on camera in probably like 30 minutes. I'm gonna drive in right now.
sounds great. And Dr. Shannon's joined, and Caroline. Brittany from Pacific Source, welcome to y'all. Jill, I think we've probably got a good crew to get started here if you want to take it away.
Sounds good. Sounds good. Can you guys hear me okay?
We can.
Yes.
Perfect. Perfect. Good morning, everyone. So Lisa and I would love to say good morning to everyone as your new co-chairs for this committee, and excited to start off this new year. Want to start with just some invitations from member announcements. Does anyone have anything to bring up? Okay. And then also invite any public comments. Thanks, Bruce. And just a reminder to everyone, if you want to enter your name and organization in the chat just for attendance purposes, that would be great.
Yeah,
Okay, with
that'd be
that,
great. I'll go ahead and let you know in a moment if we've got a voting quorum, as there are two topics that we'll be looking to sort of take a vote on today in terms of our direction. So we'll let you know in just a moment. Thank you all for putting your names in the chat. Jill and Lisa, it does look like we have a voting quorum today.
perfect. So we can go ahead and move forward with the CAP member survey results. Jamal, if you want to jump into that.
Certainly. So appreciate everybody who took the time to complete the survey, send in your feedback. As Jill and Lisa come on board as our co-chairs, we really want to ensure that there is, ample opportunity for engagement and building sort of that connection across our clinical advisory panel. Taking a look at some of the results here. So 14 of you all had a chance to respond. We asked whether there was any preference for having the clinical advisory panel meeting a different day of the week. Overwhelming majority want to keep the same day. And understanding that we've got a lot of priorities this year and a lot of activity as we're driving investments out into the community. There was a question around extending the meeting an additional 30 minutes. There were about 4 members who were opposed, who responded that they're opposed to extending the meeting. Others who were in favor showed a preference for actually adding 30 minutes to the front end of our meeting. So a little bit earlier of a meeting, which is something that we can all sort of talk about if that's the direction we want to move forward. In terms of the priority areas that folks were most interested in participating in, participating in the Access to Care Improvement Initiative was folks had the strongest interest in being a part of those activities, which is awesome. We've got a subcommittee coming up that folks can join and participate in a little bit more directly. There was more varied interest across our other priority areas, including policy advocacy, our QIM strategy in partnership with Pacific Source, and helping to direct the social determinants of health and kindergarten readiness quality improvement investments that the work group has at their fingertips to get out into the community. And then again, looking at bringing our advisory body together for more in-person engagement and sort of team building. We asked what the preference was in terms of, potentially lunchtime events or dinner events or more sort of networking happy hour events. There was a slight preference towards evening networking happy hour events with lunchtime events sort of coming in at a close second. So those were the results of the survey. I'll sort of send it back to Jill and Lisa to kind of open things up for discussion and talk through how we might sort of modify our operations moving forward in the new year here.
Yeah, I feel like currently just keeping the meeting on the current day, the current duration, and then possibly just adding time as needed depending on the depth with which we have to dive into certain projects. So we'll keep it as such currently. And then moving forward regarding evening happy hour networking events, I just feel like it would be great to develop some cohesiveness within this decision-making body. And spending time together, I think, makes some sense as we kick this year off. So perhaps the next best movement would be to send out perhaps like a questionnaire or a Survey Monkey, maybe Jamal, to find out availability of members to set something up.
Yeah, that'd be great. I can start to develop that and send that forward to the group.
I want to highlight comment that Caroline just sent out. Kudos to Dr. Shannon and the WVP team with Salem Kaiser School nurses and everybody for their efforts on the school exclusion day. Good job, you guys. Monumental efforts, I'm sure.
Huge. Thank you all. Okay. Dr. Pearson, do we want to facilitate any more dialogue amongst the group here, or would you like to move forward?
I guess we could open it up for any discussion if anyone has any comments. Okay, so we can go ahead and move forward maybe with setting up your questionnaire for upcoming networking opportunities.
That sounds
And move
great.
to the next section.
Absolutely. So yeah, folks can kind of look for that questionnaire in the next week, and we'll get something on the books to bring everybody together soon. Okay. So Lisa, we'll turn it over to you to introduce the topic.
Okay, good morning, everyone. Great to be here with you all. And again, I'm going to send another shout out to Dr. Shannon and the team for the hard work, having the privilege to see what all that requires and takes here internally and how hard her and the team were working supporting the schools and the schools coming together, the nurses and the school district. It's just really a warm fuzzy thing to know that this team is out there making a difference. So again, kudos. But now back to access to care and the shared savings proposal. Do we want to go to the next slide? So this morning we have an action item and we have a couple of takeaways. This is the summary of the Marion Polk Action to Care, the target items that are a result of our own feedback with John Creech and the survey in the community. And really what we're looking for is a decision and a commitment of allocating the remaining 1.35 million and a vote from this group. One of the biggest decision points that we need is how to allocate those funds, and the recommendation really is to appoint that to the subcommittee that Jamal mentioned, not necessarily to holistically determine where that money goes, but to create the details and the work plan based upon the feedback of the survey, and then working in conjunction with the Health Innovation Investment Work Group of how to distribute the dollars. So really we want to have from the group a commitment and a motion to move forward in the subcommittee because that is a board priority along with a CHIP priority. And then having the approval of appointing the dollars to the subcommittee.
Yeah, and Lisa, I'll chime in as well. From the discussion at the January CAP meeting, members wanted a little bit more of a detailed work plan in terms of how the 1.35 million could be allocated. I think part of the challenge there is that we really intend for that impact subcommittee to create more of the detailed structure around implementation timelines and the organizations that might be contracted with to drive forward some of those access improvement efforts. However, based on the activities that were recommended within the Creech Consulting report and other priorities through the community health assessment, we did want to bring forward just sort of a high-level action plan or work plan here, as you can see on the screen, that sort of captures what some of those activities coming out of that impact subcommittee could be. In Q1, looking at really the establishment of the subcommittee, the charter, getting the right folks at the table from our key partners, and putting that detailed work plan down onto paper. And then Q2 really sort of driving forward the access improvement efforts. Some of those recommendations from the Access to Care report included identifying primary care partners that are wanting to advance their team-based care within their practice as part of a pilot, creating a space for clinicians across our region to come together and feel a sense of belonging and networking across care settings in that Marion Polk Clinician Connect. Also, potentially embedding AI, artificial intelligence scribe technology in a selection of practices across our region to improve provider capacity and satisfaction and face time with patients, as well as provider wellness surveys. Q3 and Q4 would really be the time period to stand up those access interventions and begin to monitor for early results in terms of our members' access to care. This would also include the creation of a data dashboard in partnership with Pacific Source in Q2. So I just wanted to highlight some of those key activities that were recommended based on input from you all and so many others throughout the community as sort of a good starting place for this potential impact subcommittee. But as Lisa mentioned, certainly not the end all be all. The impact subcommittee is one that would explore other access improvement efforts, including what was discussed last month around workforce development. So having those key partners at the table, such as the Willamette Workforce Partnership, will be important for those kind of discussions as well.
With that, Jamal, do we open it back up to members for any additional comments? Questions?
I think this is one that we want, pretty robust consideration from the group on in terms of the direction that we move here. And so I think that this is really around that starting place in terms of establishing that impact subcommittee and creating the structure to drive these funds out into regional access improvement efforts. But there would be fairly robust reporting and opportunity for steering these funds on an ongoing basis. And so, why don't we open it up to the group for discussion and comment and questions?
Good morning. This is Manu. So again, I'm driving, so I hope my thoughts are properly communicated. So first off, thank you for taking back the comments that we had at the last meeting and kind of grinding through a little bit more about or kind of solutioning around it. I I'm open to accepting it as it is to move forward. A few comments I would like to make for consideration as additional conversations are had. Number one is it would be great to ensure that we have all healthcare providers represented on the in the subcommittee, just so that that potentially the conversations that are being had, while all are well intentioned, may not be as comprehensive or inclusive. And so ensuring that we have all the healthcare providers that are touched by the CCO model are a part of that conversation for distribution of these funds. Number two, the ideas such as the scribing component will probably only touch a small subset of the healthcare providers. And being a non-medical healthcare provider myself, I feel as though that whatever investments are made, like good ideas or like the Clinician Connect programs or bringing in all different healthcare providers to facilitate conversations and break down these silos. So that's kind of where I would like to see the money kind of go, as opposed to technology for one potential subset of the entire group. So, but again, thank you for grinding through it over and taking the comments and thinking through it more. And I'm open to accepting it as what's been proposed today.
Thank you.
Great, thanks, Manu.
Any others?
This is Caroline King. Just a comment about the subset that would benefit from the AI scribes. I don't know how exactly we would operationalize that, and I guess I'm interested to know how wide it could reach and how sustainable it would be for future providers that wanted to also benefit from it. I personally and my organization wouldn't need it. We already have it, and that's fine. I think it's a great thing, and I think it's great that others that can't buy in bulk like we can could be part of this program. So I don't know if others would feel more comfortable with the AI scribe thing if we could flesh that out with a bit more of a realistic concept of how many could benefit and how it could roll into future years for future new providers coming into the community, maybe also benefiting.
Thank you. Jamal, would it be fair to say that these are suggestions and recommendations, but that the details, as you mentioned before, that's what would be driven down into the subcommittee? So these are great comments, but the examples stated, granted, they're from feedback that Don Creech gathered, but really those two subcommittees drilling that down would help further clarify where.
Yeah, I think they're incredibly important points. To Manu's point around other healthcare providers being at the table, the access to care report hinged on reviewing access to not just primary care, but also behavioral health and oral health care within our region. So very important point, and one that I think is central to this effort as well. And to Dr. King's point as well, yeah, I think this subcommittee, that would be part of their order of business, is evaluating AI scribe vendors, the amount of clinics and providers that could be brought on board with the amount of funding that we have available. And then also looking at, once we get out towards Q4 and we're evaluating these, how these interventions are performing within our community. That's where we're sort of looking to establish sustainability plans and how best we scale these activities beyond 2025 if they are improving access and improving providers' satisfaction with delivering care in our region. Great comments, though. Other thoughts or questions from the group?
This is Matt Hatler. I agree with moving forward with this as a concept to develop the committee. I think there will be a lot of discussion when fleshing out things like AI and time saved per encounter, because it's I'm not a dentist, so I have no clue like how long it takes to document. But I know for things like a well check with a complicated kid, that's like 15 to 20 minutes of documenting alone. And so AI could be very helpful.
Thank you, Dr. Hatler.
So Lisa, it sounds like there's some support for potentially moving forward with the initiative here. Did we want
Do
to
we want to
ask?
open up for a motion and a formal motion to move forward
Yeah.
with allocating? The motion would, Jamal, do you want the motion for the funding or for the subcommittee or both?
Yeah. I mean, it's really up to this group, but I think we can sort of group everything together if folks are comfortable with that.
Would you like us to make a motion? Is that what's on there, or how would you like
Yes,
to?
please.
Okay.
Yes, please.
Oh gosh, I'm the one who first spoke. So I like to make a motion for the funding of the 1.35 million, and then also make a motion to for the committee. Is that correct? Sorry,
Yes. Thank
hopefully I'm tracking. Okay, perfect. Yes, awesome. Great, thank
I'm
you.
going to tease you and say I think you volunteered yourself for the subcommittee, but that's another conversation.
Yes, I probably did. Yeah, I volunteered for it. Please put me down. Thank you.
You're welcome.
Felt more like a voluntelling, but
Yeah, no.
anyways. Okay.
I'll second. It's Matt Hatler.
Thank you, Dr. Hatler. So all in favor?
Aye.
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 Any opposed? Okay, wonderful.
We should ask for any abstentions as well. Hearing no abstentions.
Okay, there we go. Thank you.
Great. So one of the next orders of business, I think, is for us to I think as a group really talk through the key partners that we want at the table for this subcommittee, and I think open it up to our CAP members and beyond to be a part of the subcommittee. So I think those are some of our key next steps, is establishing membership for that body and getting ready for our initial meeting in March.
Should we send out a communication or just have the members, any interested members, send us an email indicating desire to participate?
Yeah, I think that sounds great. So I can send out a follow-up summary following this meeting, and maybe we'll include a question there for folks to kind of follow up with Lisa, Jill, and I on your interest in being a part of it, or if you think there are key members throughout the Marion Polk community that should be a part of that subcommittee.
Jamal,
That's
do
a good
you
question.
have an idea of time commitment? I'm so sorry. I just thought it might be helpful to say what time commitment. you're anticipating.
Yeah, that's a great question. So I envision that being a 1-hour meeting once a month. For the co-chairs that would sort of co-chair the committee, there'd probably be an additional planning meeting tacked onto that. And then maybe another hour or two as in the early going as we're reviewing what access improvement initiatives to advance in the community, potentially looking at vendor specifications for team-based practice facilitation and AI scribe technology and other activities that come about. And so I think members could probably anticipate an extra 90 minutes to 2 hours a month to participate in that subcommittee.
Thank you.
And quick question, do the members of that committee need to be on the CAP, or can they be like, say, other people from my organization?
Yeah, I think the goal is to bring in subject matter experts from all across the community, including folks from Willamette Workforce Partnerships, potentially our educational institutions like CTEC and Chemeketa and WOU, really across the community to make sure that we've got as much expertise at the table as possible. So that's the goal, but not necessarily tied to that if our membership feels strongly another way.
Any other comments on this? Or if not, we'll move on to our next agenda item.
Great, Jill, why don't I turn it over to you?
Okay, so moving on to the next big agenda item is the Social Care Impact Fund. This is a huge summary topic that was put together through the Health Innovation and Investment Work Group. So just to highlight that the efforts, I feel like Jamal, maybe you have a little bit more history to kind of give a better overview of the purpose and the impact before we move on to another invitation for a motion to approve.
Yeah, thanks, Jill. So our Health Innovations and Investments Work Group was allocated about $1.9 million, as I think most of you are aware of, related to the social determinants of health QIM, as well as the social emotional health aspects of kindergarten readiness QIM, really to drive investments into the community to build, sustain, and expand capacity around screening and referral for social determinants and social support services, as well as ensuring kiddos going into kindergarten are ready from a social emotional standpoint. So the two measures here had that $1.9 million associated with it from 2024 infrastructure and capacity building QIM funds. This slide just kind of shows a little bit more about the exact dollar amount that's associated with each fund or with each QIM. One of the key aspects that we're looking at here is the work group has put a significant amount of time into determining how best to drive these funds out into our community partners and provider organizations that are not only building the capacity to provide these social and emotional support services, but also to sustain those operations that are connecting members to the care that they need around the social determinants of health and kiddos' behavioral health needs. And so there's an application process that's been developed to drive those funds forward in really an equitable way and in a way that prioritizes creating broader alignment across our community around best practices and gaps in our community, piecing in gaps in our coordination and data sharing. So I'll kind of walk folks through some of the process that's been developed here. So when we talk about some key areas that we as a work group and in looking at Pacific Source's action plan for the community, which is informed through their environmental scan and gaps analysis, The Social Care Impact Fund has a number of priority areas that as applicants apply for these funds, they would receive additional priority or weighting if they're selecting that they're utilizing or integrating these particular priority areas within their application. So when it comes to the social determinants of health screening and referral QIM, we know that there's a major investment in Unitas as the sort of community information exchange for our region that allows for better closed loop referrals across the community and understanding when folks need social support services and they're referred out, if those folks actually made it into their housing support services or to get the nutrition and food supports that they need. So sort of that closed loop operation. That platform is also sort of forming the backbone for the health related social needs benefit. So the new benefit that members on the Oregon Health Plan have access to as those referrals are going through Unitas. So a great opportunity for entities that are conducting screening and referrals through Unitas or would like to integrate that platform into their native electronic health record system or case management system for their community-based organizations. This is an opportunity to receive extra priority as their application comes in. Other priority areas include doing the work to establish formal partnership agreements for coordinating services across provider and community-based organizations. Investing in the staffing for direct service delivery, and also the data entry personnel, as we know that screening for social determinants and as well as understanding if folks have already been screened and preventing over screening as under the auspices of really conducting a trauma-informed approach. A lot of that is really supported through having the right data entered in a timely manner. And so that's one of those areas that we also wanted to prioritize. Under the social emotional quality incentive funds, the priority areas are really around identifying folks within practices in our region who would like to take trainings, get certified, credentialed, and to be able to provide the behavioral health services identified under this QIM to ages 1 through 5. So if there are folks at behavioral health practices that would like to take trainings and certification to be able to serve that population, this is an area where folks could receive additional priority for their application. Similarly, in primary care settings, if there are licensed clinicians that where there are trainings that folks would like to take in order to serve kiddos 1 through 5, this is an opportunity as well. I do see that Manu, you've got your hand up. Let me pause and open it up for question.
So this is kind of more of a technical question, and you may or may not know the answer. And so, as everyone probably on the call knows, Capital performs all of the OHP dental children's outreach, in the region here, and the 1 to 5 year old population, 6 to 14-year-old population. And while I don't recall exactly the total number of kiddos we saw that were 1 to 5, it's over 15,000 through our outreach program. And so the reason why I preface this ask is I hadn't thought about this until now, but this idea of training, certification, and credentialing, could a expanded practice dental hygienist or essentially a dental provider be credentialed, not credentialed, but undergo this type of training in order to participate in eclipsing this measure? or is that not possible? And again, I don't know much about this, so it's more of a knowledge-based question.
Yeah, that's a great question, Manu. And you know, I would sort of open. I know that Brittany with Pacific Source and who's very closely tied to the metric is online if she'd like to chime in. I do know that there is a specific code set associated with this quality incentive metric, a set of largely behavioral health centric procedure codes that are, you know, effectively what count as the numerator for an issue-based intervention is what they call it for young children. That would sort of move performance for the region. And so I imagine that the evaluation of applications will likely hinge and prioritize those entities that are building towards that specific code set and or sort of the infrastructure and capacity that leads towards kiddos getting into those particular behavioral health assessments and issue-focused interventions. And so, Manu, I think it's more so a conversation of working with your organization to understand the specific service in a little bit more detail and how that might be coded and billed for, and if that sort of amounts to the or sort of registers under that code set, or if there's something like a coordinating agreement that could lead towards kiddos being connected into those issue-focused interventions. I think there's certainly a pathway for that application to be considered and funded under this bucket.
Jamal, I would add that I attached in the chat the link that's embedded in the presentation around the specifics of the measure and who's eligible in code sets.
Thank you. That's helpful, Lisa. And I do see that Chris had a question in the chat as well. But Manu, just to sort of wrap up there, I think if you wanted to have a conversation with Brittany and I and Jill and Lisa offline on the initiative that your organization might be able to bring forward, the Early Learning Hub is also heavily involved with this metric as well. I think it'd be great for us to connect and talk that through.
Okay, great. Thank you. I'll reach out later today.
Great. Thank you. Chris had a question around, has Unitas decided to allow integration? I did speak with Zaira, our local CCO Pacific Source director, a couple months ago, and she indicated that they were beginning with integrations with entities that were using the Ochin Epic electronic health record. Typically, health IT vendors, major health IT vendors such as Unitas, have an integration package that's available to entities. I think it's probably one of our key next steps is to get a little bit more connected and directly with the Unitas team. I know that folks at Pacific Source and rolling out the health-related social needs benefit are pretty closely tied in with those folks. So there, we have heard there are some integrations that are being prioritized right now, and so this would create an opportunity to potentially receive funding to connect with Unitas and embed the platform more natively within those electronic health record systems or case management systems. As we know, being able to have that information right within your record and to pull up patient records within Unitas as you're pulling up records within your native system, it's going to save clinicians a lot of time, not having to remember passwords for some outside system, as as those are often burdensome things to uptake on these kinds of platforms. Great question, Chris, and I think we can follow up with more detail as we connect with the Pacific Source team and our contacts at Unitas.
Okay, thanks. Because I mean, most of those sound more like the medical provider, where our partners that work more in the social determinant of health use other systems. So that integration would be very important at that time.
Absolutely. Okay. I see another question from Jody in the chat. Would this partner with schools at all? We are seeing many kids not at basic kindergarten readiness. Example, not potty trained, social emotional. So once the screener is done, much support is needed for family support. Would that also be included past screenings? Yeah, and I, Brittany with the Pacific Source team can attest to this. Most of the metric around social emotional kindergarten readiness is for the issue focused intervention, not necessarily basic screenings and assessments. And I believe there are some codes within that code set that are sort of more group and family centric. That would certainly, if there are initiatives that address the sort of have more of a holistic approach in addressing the family, I think that those would be strong initiatives to bring forward for this funding.
Yeah, Jamal, I just want to second that the social emotional health metric is really going to be about those interventions that largely happen sort of in a behavioral health space, whether that's specialty or primary care behavioral health. But I think it's important to recognize that part of our work is really about sort of supporting families on their path to accessing services too. So I appreciate you pointing that out, Jody.
I'm going to keep us moving forward here, as we are hoping to sort of adhere to a timeline here to get this out into the community and available for taking in applications sooner rather than later. So I wanted to kind of cover the process here to ensure we have ample time to discuss and hopefully make a decision on if this is the right process to roll out in the community. We would roll out sort of an application for the social care impact funds that would serve as a single application where applicants would indicate within the application if they're applying for the SDOH QIM funds, the social emotional health QIM funds, or in a more holistic approach for both funding pools. The application timeline looks like the Health Council really generating pretty far-reaching communications out to the public starting March 4th. And that would include hosting a webinar on March 19th around the application being open. So the application window would actually open March 12th and be open through April, what do we have here? April 28th. Our Health Innovations and Investments work group would be involved in evaluating those applications. So with the application window closing on April 28th, we would kick off evaluations through the Foundant grant tracking system on May 2nd. And so those evaluations would go from May 2nd through May 19th. And then we would look to the May 21st Health Innovations and Investments work group to kind of have that final discussion and touch base on the results of those evaluations and scoring, which I'll touch on sort of the scoring methodology in a moment. Sort of reaching that final decision and discussion point on at the May 21st Health Innovations and Investments work group meeting. From there, our grant management team, Melissa Lindley and Allie, would generate the notice of awards to the approved entities on June 2nd. We would receive the signed letters of agreement that we would embed within our Foundant grant tracking system by the 27th for projects to begin or begin receiving funding for sustaining existing practices starting August 1st. There is initially sort of a funding cap of $250,000 per application that folks would be that folks would have available to apply for, and funding would be available for use from August 1st through January of 2027. Really quickly here, looking at the evaluation criteria. So we've laid out sort of 5 key areas where applications would be scored upon with 100 points total possible. Number 1 being that overall community-wide impact. So what's the return on investment for the Marion-Polk community? The feasibility of what's being proposed within the applications. The sustainability plan that organizations have. So beyond the grant funding period, how do entities intend to sustain their practices? Their budget. So what's the cost effectiveness of the budget that they're moving forward? Really ties into number 1 as well in terms of that return on investment for the amount that's being requested. And in terms of the outcomes and outputs that they will be reporting on, how achievable are those measures, and what's the confidence that we would have that folks would be that the applicant is able to report on those measures. And then, as we discussed previously, there are some priority weighting areas. So for each of those previous priority areas that we discussed, folks could achieve an additional 5 points per priority area that's integrated into their proposal. I'm going to pause there for a moment. Melissa, did you want to, from the grant management team perspective, did you want to chime in or cover anything else that I left off here?
No, I think you covered it so well, Jamal. And just for clarification, the projects would end by December 3rd, or the funded part of their project anyway by us, would end by December 31st, 2026, and their final progress report would be due in January of 2027.
Thank you. Thank you for that important clarification. Last couple things here. So this just kind of goes through the evaluation process a little bit more. So our Health Innovations and Investments Workgroup members would individually score these applications within the Foundant grant tracking system. We would then have that aggregate scores compiled and sort of that aggregate review session at the May 21st Health Innovations and Investments Workgroup meeting. Those award decisions would be final. And so there would not necessarily be a process of coming back to CAP for individual approval of awards, but there would be reporting out of those award decisions and the entities that have been funded and their initiatives at the subsequent CAP meeting in May. I want to pause there. I know that we've got about 9 minutes here. This is a process that we're excited for in terms of generating some much needed funding for the community to conduct this important work around screening our members for their social determinants of health needs in the most efficient ways, in trauma-informed ways, as well as ensuring kiddos are ready social emotionally for kindergarten. I'll stop there, and Jill and Lisa, I'll kind of turn it back to y'all to kind of open it up for dialogue and discussion amongst our membership.
Great, thanks, Jamal. That was such a nice, succinct summary of a process that I'm sure has taken a lot of time for this group to come up with. So I just want to open it up for any conversation or dialogue.
I have a comment potentially, just wanted to discuss. I met with Bhavesh before he went on vacation, and one of the items that we were hoping to look at, I think a bit deeper, Jamal, is the funding priorities around the SDOH monies specifically. So I don't know if this is the forum to really kind of discuss and see about ability to refine some of that. But otherwise very excited about sort of the process and the work group and all of that.
Yeah, Brittany, I think it's certainly if there's a suggestion, I think this is a great place to propose and perhaps we can integrate that and move forward.
Sure. So one of the suggestions that we had was around sort of prioritizing the use of UNITA to meet the SDOH metrics this year. Really feeling like that is a great long-term solution, and also hearing from providers in the community that they're really in need of sort of something to support data collection and reporting that will help them close the metric this year. And so really was hoping that we could have a discussion about adding a priority area potentially, or sort of widening the scope of that priority area to include other methods that providers may use to report data on this metric specifically.
Yeah, I think that's certainly something that is worthwhile for this group to consider. Priority area 4 does sort of not directly speak to the myriad of data collection methods that are out there, but it does allow for entities to receive additional priority for their staffing and operations that are tied directly to data entry, which presumably is also in collecting and storing and being able to view folks' social determinants of health screening and referral history. I do think that that's an area that is sort of captured there. In terms of Unitas, that is an area that there's a lot occurring to centralize that as a space for the health-related social needs benefit and a lot of different operations. And so understanding that not everybody is on Unitas, I think we're sort of looking at this as a good opportunity to provide a little bit more encouragement for folks to come onto that platform, as it's going to create more of an opportunity for data sharing and coordination across the region as well. So sort of an amplifying effect, not just for those entities that are on it, but for those that are looking to coordinate with them as well.
Jamal, I still would want to say, when we talk about social determinants of health, we're really talking about a couple sets of providers, and sometimes we need to look at what's going to support our social determinants of health providers outside of those medical clinics to do their work the best, to get their outcomes the best, to be able to work with those practitioners. So I hope we do open up and are open to looking at those different ideas. There's several different platforms out there.
Yeah, absolutely. great discussion. I think very important elements to sort of integrate into this process as well. Lisa and Jill, and I think to the larger membership, I would sort of pose it to folks if folks feel comfortable launching this application process with the caveat that some of the comments that have been discussed are also integrated.
Jamal.
Yeah, well, go ahead, Bruce.
Oh, I was going to say, hey, I got to run it with patience, so I hate to kind of leave on a good question, but you know that I actually proposed this question to you back. I had to go look real quick through my records here. It was back in December, because I feel like the tough part of this situation is that by voting for this newer method, we've completely cut off a large portion of how we can help in the community because it became very focused. And you even said this has become very focused on behavioral health, on integrating behavioral health into medical, which to me, it cuts off a large opportunity for public health efforts, because according to the guidelines, which we were just presented with, it just really cuts down on the ability. I mean, I only see this as helping really one area now, whereas before under the old method, we could hit a multitude of areas and a multitude of providers, because I definitely want to be included in with Manu's inquiry, and I can even send the responses from our December discussion, but I feel like there's no opportunity to help dental. I feel like it really limits the ability for any medical or any other group to ask for help, because it's now suddenly become just all about behavioral health. And don't get me wrong, behavioral health is needed, but it's like this has really cut down on the ability for us to be broad in our scale to help.
Yeah, it's an important point, Bruce. The OHA code set that they've sort of attributed to the metric, it is fairly behavioral health centric. That being said, with these QIM dollars, we do have flexibility to invest in infrastructure and capacity building that either directly contributes to metric performance or indirectly leads to coordination and services that connect into those more behavioral health centric services. And so that's where I think there's an opportunity, particularly for oral health, to play a role. And we could certainly, as Brittany and I have that conversation with Manu, bring into those conversations as well.
Small group, this is Lisa. With the amount of dialogue and open-ended questions, is this one that rather than asking for a vote, we need further discussion, or do we feel comfortable enough to request for a motion? I know we're at the time.
Yeah, I think we are on a tight timeline that we'd hate to push back, and so
Okay.
I do. I think if folks do want to make a motion to kick off this process, we can advance it forward. But otherwise, we can certainly potentially come back at the next meeting or in between meetings.
Well, let's just go ahead and open it up to see if anyone wants to make a motion and get an idea of approvals. Is anyone comfortable at this point making a motion for approval? I don't hear anyone approving at this point in time. Jamal, we feel like we need to have maybe some more email conversations within the group just to make sure that all the questions are answered and everybody has a chance to participate.
Yeah, I think that's a good next step. So we can continue the conversation through our follow-up communications, and if folks are comfortable, we do have our sort of e-voting process, which is part of our charter, if we want to move through that route as well. So we'll certainly follow up with folks and make sure that folks have a good amount of time to really consider the details here.
We're losing attendance for quorum, possibly even. I don't know what that number was, Jamal.
Yeah. Let's see.
We're getting more discussion. Yeah. Thank you, Lavinia.
Yeah, we do
Okay.
not have a voting quorum any longer. So yeah, we will need to follow up.
We're past time, so should we just move to our next steps and summary?
Yeah, I think moving to next steps would be great. Yeah, let me just kind of turn it over to you, Lisa and Jill, if you wanted to cover next steps.
Yeah, so I
Jill,
think
do
the
you want me
next
to
step,
just-
big action item would be just following up with email conversation, just so everybody can participate in their reservations or concerns, and before we set it for an e-vote option.
And then for the access to care, there will be in Jamal's summary of today's meeting, as well as opening it up for members to volunteer for participation in the subcommittee. And I thank you for the passing of the 2 motions on the subcommittee and the commitment of the funding for their review.
Wonderful. And I'll also follow up with that questionnaire on sort of an in-person networking event and what works best for folks, as we certainly want to bring this group together a little bit more often.
And then more to come on the SCIF priority, more discussion to follow.
Alrighty. Thank y'all so much.
Thank you.
Yeah. Thank you. Have a
Take
great
care.
day.
Thank you. Bye, everyone.
Hi.
Thank you.